I'm going to pause this.
Yeah, it's very frustrating.
Yeah, one of the brand new nurses was in the ER and she had a intubation. And he was talking to us about straining. And I said to her, nothing, brand new out of school. So nothing, I said, you need to of that. Yeah. And she says, in my experience, and I'm like, in your vast experience of, in handling ER patients that are vented and on
you get a lot of that down there, do you?
Yeah. I said, and I turned around, I walked out, and everybody was like, what's wrong? Because I would have it. And, just, what's wrong? Yes, this is what's going on. It's like, what?
So I know everyone doesn't have the textbook, so I'm going to give you a scenario out of the beginning of this chapter, just to contemplate before we'll talk about it after a while. So in emergency medical services, as an emergency medical services provider, you're faced with a personal and professional decision today. You have, so that has you feeling a lot of stress. You've been suspicious that your best friend and partner you have been coffee. You have been suspicious that your best friend and partner for several months, and you're worried that he is using and possibly stealing controlled substances. This is not the partner and eventual best friend of you that you've known for more than 5 years. So you actually never witnessed him taking drugs, nor has he confided in you that he has. However, his behavior has been erratic. He displays sudden signs of slurring, uncoordinated walking, and poor eye-hand coordination while working. You've been helping him with patient care, making decisions, and correcting his errors in judgment, dosages, treatment before he actually completes them. Said you confronted him at work last night between calls, and he became defensive and angry and now refuses to speak to you. The department's rumor mill is telling of an unaccounted for controlled substance. Your personal challenge is that he's your friend. You'd like to get him some help without jeopardizing his job, family, or your friendship. You have professional challenges. So do you think it's so that you think you could be placing your own career in peril by not notifying your employer and licensing certification board of your strong suspicion? Then there's a third real dilemma, so that you're worried about your partner's decision to make it and take care of patients in the most effective means. Have you ever had to deal with a challenge like this?
Thank God, no.
Not somebody I knew. I mean, we had people in various stations that were abused there, but never anybody.
Had to be involved in one of these. Not as in depth as that. Not my direct partner, but a coworker, and someone I consider a friend. Someone I consider a friend to this day. And probably the reality check that they got was, and I may not have handled it the most appropriate way, legally, ethically. So, but I was younger and dumber. I didn't have a license to protect as much as I do now. But I think that reality shock back probably improved their outlook and quality of life. We got a little bit of help. Theirs weren't nearly as, they weren't stealing controlled substances. That's a problem. If I had skirted that and not reported that, I think I'm just as guilty as anyone else. If you're stealing controlled substances, you're going to go to jail. I mean, that's what's gonna happen if you're doing that off an EMS truck. But we're right for it, right? Yeah, here's this big box of drugs. Here's this. You got enough fentanyl to knock down the neighborhood. I mean, how much fentanyl do you carry on your truck?
5 miles to 1,000 biker carry.
1,000 micrograms. That's a lot of fentanyl. You know, and how many passwords do you have to put in to get it? Right,
Just a key.
just a key.
No,
You don't have to do that.
The same thing.
my pretty little finger will get me to it.
That's better than it used to be.
Oh, yeah, it's true.
There's some trucks we don't, that are our old ones, where our new ones go out of service, we don't even have them under lock and key. I keep them on me though, I keep them in my pocket.
Yeah. I source some services. I carry them in my flight suit pocket because where are you going to be? Where is it? Is it locked up on a tarmac? Is it in your jump bag? So there is certainly ripe for the taking if most providers are ethically and moral enough to not do that. We'll talk about that scenario a little more too.
What do you do? Like, you've got one person, we have one person that work with us, that I don't know what she was taking, but I mean, she would get like sloppy, couldn't talk. Higher ups knew it. We had gone to her or gone to the higher ups, but nothing was ever done. They said that they had run drug tests on her and that she had a prescription for everything. And I said, well, I don't care if she had a prescription for it.
Yeah, I don't.
It's still, if she's that out of it,
If she's shitty at work and you can't make a decision.
That's dangerous.
yeah. And that's what so I was like, yeah, I don't want to work with her.
I will say, I actually did watch this actually happen 3 weeks ago, but we had somebody fall asleep at work
Yeah,
because
she's
they
done.
were high.
And she would stand there.
That was their last day at work.
And she would stand there and she'd be eating
I completely forgot about that.
And like I said, we actually took it on video and our higher ups saw it.
That's disturbing. In my instance, if that person's responsible for patient care, you're done. That person's getting off my truck.
No, and she's a paramedic, and her partner was an EMT, and there were a lot of calls that she pitched to her EMT that probably should not have been. But her EMT was like, which would I prefer for her to do? Be in the back trying to take care of a patient or driving? And I was like,
Kill us both.
yeah. I was like, geez.
That's
If she couldn't take care of
I said,
patients.
well, first of all, I'd be calling the supervisor, captain, and be like, you need to come out here. You know, that's just freaking ridiculous.
on the second side of that. After beyond even that, where's your obligation? Okay, we've done that. You have evidence essentially.
Yeah.
What's the obligation to report that to our governing body?
Yeah. That's what I said.
OEMS or to our licensure
I think
board.
that's what finally happened is somebody went to our higher ups and said, if you don't do something, we're going to call the state.
Like I'm be on the phone with Doug.
And it went on for 2 years. Not just a short period.
That's dangerous.
2 years.
That's absolutely dangerous. So back into SCT. Patients who need critical care transport are those who have critical injuries or illnesses resulting in unstable vital signs and need transport by a transport team with the appropriate levels of care and capabilities to centers that are able to provide definitive care. Or they need a higher level of care during transport with lack of critical illness or time critical illness or injury. So they may not be at that point of being critically ill yet, right? But we anticipate their deterioration en route. And this comes down to, even on your medical necessity form, the risk of death en route. How many times you take a patient that's checked? Just throw it out a lot. I mean, I think
because they started out stable, they were stable for transport, doesn't mean they remain that way.
Yeah. But it doesn't. But legally, is that patient really at risk of death? Other than we're driving them down the road at 60 miles an hour. So I guess technically, you're a risk of death. You get in the back of this ambulance, especially when you're working with that partner you're talking about.
Yeah.
You know, but deterioration is what we're talking about. That patient very well may be stable, but runs the risk of deteriorating. Why critical care transport? So you have, why it's not being pushed so readily. From a local perspective, it costs a lot of money. There's a lot of money into securing the equipment, to making sure you have the team, the resources dedicated to this. There are different reimbursement schedules. For a true specialty care transport, the reimbursement is much better than a ALS2 transport. And by the way, Medicare is, by the definition of it, a patient on a CPAP, not, a actual CPAP that's run through a ventilator or a BiPAP, would qualify under a specialty care transport.
So you're saying the one that I hook up to
That's not going to work. That's not going to work. But a vent-driven CPAP or BiPAP technically falls under the category by CMS as specialty care transport. If you could do a lean program, and lean is a financial model in order to show waste and show a cost-benefit analysis to organizations as to why specialty care transport is a positive thing for you financially. They'd be like, oh, this is a no-brainer, but I want to grab that door. I don't know if it's open. There's a lot of dynamics into government as to why we don't do it. EMS has always traditionally been the whipping child of most places.
Everybody.
Yeah, I mean, you're the last ones to get funded, you're last ones to get raises, last ones to get new equipment. You're driving trucks with 200,000 miles on them.
Our new trucks are not scheduled to go out of service till they get
300,000 miles? Wow. That's when they're scheduled to go out of service.
do what?
That's when they're scheduled to go out of service. That's amazing. Good luck.
Now, they're second new trucks at that point, but
Wow. There are, federal statutes in TALA and COBRA that relate to transfer requirements with appropriate staffing, liabilities about sending crews without appropriate training. We mentioned that yesterday just briefly about the crews that left Vita Medical Center that were not equipped and not trained in how to monitor waveform capnography, nor had the resources to it. And look what it costs. Aside for $13 million, look what it cost. It cost the life of a 9-year-old. So when you look at it in the big picture, what is $250,000 to start a program? $13 million, the life of a 9-year-old. What's the cost? So staffing requirements, it is no longer cost effective for hospitals to give you a nurse to transport, essentially. When I say pull from floors, if you have a critical patient, they do not want to do that for a number of different reasons. One, it affects their census. They have remove a nurse from patient care, they have to bring another one in. So they're expending more money at that point. The other one, they're not making any more money on that patient. And I come down to dollars and cents because we do. We know exactly how much money every patient generates at any point in time. And it's not all about money, but the doors have to stay open, right? I like getting paid. So, and depending on what department you're in, it is all about money. I mean, that's, if you're in finance, it's about money. That's it.
Well, too, it also puts a legal burden on the hospital if they send a nurse with them, correct?
That carries extending to some aspect because they're not trained in order to be able to do that. Yes, okay, I need to initiate blood route. Great, cool. She's able to do that. She or he may not be as familiar with riding in the back of an ambulance and slips and falls in the back of a truck because he goes around a curve and they're not anticipating that. They're not used to that. The floor doesn't move. You get hurt. That creates a huge legal liability on them. So there's all kinds of different reasons why. Plus, nobody wants to go. I mean, nobody wants to do it. So, professionalism. When I say professionalism, what image comes to your mind? It doesn't have to be EMS. Like when you say someone that evokes professionalism, what do you think?
The way that they're dressed, their appearance. I mean, they're first and foremost their outward appearance,
okay,
and how they handle themselves articulately. Even, I mean,
absolutely.
Their
So-
giving report,
Way they
report.
before they even get there, their demeanor on the telephone. Well, I'm developing an opinion before they even go on the telephone. When they show up, when these trucks are pristine and beautiful. That picture sucks. I'm sorry.
They don't have to be spotless, but they don't need to have 5 days of grinds on.
Yeah. And you wonder why. Yeah, you're right. I mean, your supervisors harp on making sure these trucks are washed at the beginning of the shift or at the end of the shift or whatever they're washed. And there's more of a reason other than just making them look good. Do you ever notice that, and I'm going to squirrel a little bit here. So, an inmate escapes from the county jail, right? And it gets publicized in the paper or the news. You ever notice who the hell the camera's on when they get there? It is not the local sheriff's deputy. It is the highway patrolman. Dressed to a T. That uniform is perfectly crisp. That hat is beautiful. That hat is on. He's professional. Why? Because he evokes professionalism. He looks good. And so, looks...
Your local patrol sergeant.
Does not.
Right.
And I'm not saying they don't, but may not.
Right.
They look good, and it doesn't matter where you are. If you're in Antio, if you're in Rocky Mount, or if you're in Murphy. That trooper looks good, and the camera's attracted to him. Is all I can get to that point. And I'll use an illustration for the point of I talk about the way they present themselves. A trooper out here on I-40 in Raleigh a few years ago stopped a guy, and he stopped him and ended up arresting the guy had arrested for warrants for 3 law enforcement officers. He arrested him without incident. This guy shot and killed 2 officers in traffic stops, and shot and killed 3 officers, and shot and wounded another officer in traffic stops. He said, "Why didn't you do this?" He looked like he knew what the hell he was doing.
What is it?
Professionalism.
Perception. Yeah.
Perception.
Perception is reality.
I'm not saying I'm not invoking this. You need to look like you know what you're doing. You do need to know what you're doing, but perception, professionalism. So first thing, like you said, that first glance, the way we don't get a lot of flight crews coming into my lab routinely until we put a new bird in. And I have a new nurse who came from a cardiovascular thoracic ICU and has been on my team for 3 weeks. And she goes, "Damn, that flight crew look good." They come through the door because, again, their uniforms look good. They're pressed, they're clean, they look like they knew what they were doing. I was like, yeah, well, they look good. That patient fucking died 4 minutes later. Excuse me, I'm sorry. I apologize. I used the F word. That patient died
I believe you.
about 4 minutes later, but And flight crew looked good coming through the door. They did what they were supposed to do, but we can't help it. In hospital culture, we must be able to adapt to the hospital environment. Remember, you represent the entire embodiment of your organization when a paramedic or a transport shows up at the hospital. They make their judgment based off of you, whether you've interacted with them or not. So you represent the entire pre-hospital profession. Just like when I go to Walmart, that cashier represents every other cashier at Walmart. So, it's a big leap. So don't judge me based off of the dumbest person in my profession. Try to be cognizant of that, but that's what's happening. So you never get a second chance to make a first impression, so make it a good one. Use common sense and respect it with interacting with hospital staff, patients, and their families. Be non-judgmental when completing assessment and care. I think this right here, complete an assessment. We see too many folks that do not, and this is we talked about it briefly earlier. When you're doing it, maybe it was yesterday, when we're talking about transporting a critical care patient, it's a much different animal. You actually have to know your patient. You need, we're used to taking them from the scene and dropping them at the emergency department and boom, boom, we're done. All that stuff is long term. We're really thinking about all that. That all comes into a factor. So thorough assessments, non-judgmental. We are terrible at being non-judgmental, but keep it on the inside. Ask before using hospital equipment. Ask before viewing patient charts. Thank the transferring facilities. Be courteous. Offer feedback. If there was a hiccup in how they got a hold of you, like if they didn't have the right number for the transfer center, make sure they have the correct information to activate your services.
Share your business card.
Yes, share your business cards. I've worked in both public, private, not-for-profit services. Customer service is a huge deal.
Even families, you know what road they're going, how to get to the hospital.
Yeah.
That's what I was trying to do.
Pre-printed instructions on where you're going.
To the hospital,
Pre-printed.
We have.
Yeah, you never thought about that.
We carry pre-printed instructions on the mix of how we're getting there, where you're going. If you have a problem getting there, the contact number for the hospital, and for us, a contact number for you if they need to get a hold of you.
Yeah.
Something happens critically, we need to make sure we're able to get a hold of you and don't follow the ambulance. That always works.
Sure.
Yeah, don't you know? That always works. Just tell them that.
I just heard you say it.
So the culture, we're used to, this is like a scene call with walls. We're not used to that all the time, but use common sense and respect when interacting with everyone. Be prepared for staffing and equipment differences from what we normally use. If a patient's on, if you're going to a different facility and they use care fusion pumps, you use broad pumps. Be prepared to change IV pump tubing. Another catch, our pumps are pre-programmed for concentrations. Make sure the concentration is the same. Because I'll give you a specific example. I get patients from a CMC hospital routinely. Their concentration on nitro drips are different than our concentration. That's a huge deal. They use the same pump. So if someone if everyone wasn't aware, didn't know that, and just swapped it over to our pump, we're going to over-medicate this patient with nitro, and that's not a good thing.
With a receiving facility one time, and totally floored the nurse, but your concentration is different. I said, okay, this is how you do this. This is how you do that. Changeover. And this is how you'll change your drip set, because she was used to, pump and the cyrels and just pump on. That's it. But this is how you do it.
And I'll get in. So we talked about this a little bit earlier, but you bring up the facility at that point. Go to pick up a patient, and this patient's on a vent, they're sedated, they're on Versed and fentanyl and propofol drip. Okay, so they're real sedated. Really sedated, like something's like, why are we so sedated? Look at my concentrations. Huh, something doesn't seem right here. My pump's been overridden. My fentanyl drip is going at 1 mic per kg per minute, based on what the concentration of the fentanyl was mixed at. That's a little bit much for sedation when you're also getting 3 milligrams of Versed and 3 milligrams an hour and propofol. So needless to say, that patient probably would have died had we not been judicious and figured that out really quick, because we're wondering why we can't get their pressure up. They had them on dopamine and levo, and fentanyl, and Versed, and propofol. I can tell you why their blood pressure is not working. Let's fix that right now. So no matter how poor you think a patient is, you think the patient care is at the hospital and your outside facility, don't tell them. Don't get into that fight. It's not going to be served by anything. It's going to be served by getting into a peeing contest with the staff. If they're pissed off at you, they're not going to call you for their next patient, and who might need help even more. That patient might be even sicker. So just be cognizant of that. That's common sense for the most part, but
Common sense ain't so common.
so we're doing professional and non-professional attributes, just comparing. Always put your patient care first, and I've said that for the last 2 days. I don't care what it is, the patient condition takes priority. I always do what's in the best interest of the patient, regardless of whether it's in my best interest all the time. I take a racking of my knuckles at least once a month for doing something that I probably shouldn't do, but I did it for the right reasons. So there's a difference between, doing the wrong thing or the right thing for the wrong reasons and doing the wrong thing. And it's not that I know I'm doing the wrong thing, it's I'm doing it without permission. So I have 17 physicians that I work really closely with. 11 of them I know like the back of my hand and I have no problem. The other ones, it's just depending on what a day-to-day you're going to do, you're going to get. So I take my brackets when I deserve them. And I'm wrong. If I'm wrong, I'm wrong. But I think if you act in the best interest of the patient at all times, no problems. I'm not encouraging anybody to deviate from protocol or practice or medical control by any means. Just understand the importance of rapid response. Practice your skills to the point of mastery. If you get there, that patient's only got 1 IV. Don't gripe about it. Just fix it, right? We encounter that. Sometimes it's a little bit more difficult than one would think to get that. So, and with the staffing issues that we run into the hospitals, we have, what's the word I'm looking for? A lot younger generation of nurses who never got a whole lot of conceptual skill in some areas. Not saying they're not bad, good nurses. They're not. They're not saying that at all. Just we emphasize different things in education programs. Take continuing medical education seriously for you as a provider. If your agency doesn't provide quality education, go somewhere else. Get it. Absolutely do it. Set high standards for yourself, your agency, and your system. I want to know what what you would do, what your crew would do in that situation. You want to go do the best you can. Review your own performance critically and honestly with yourself. That's a huge one. If I make a mistake, I want to know why I make a mistake. Because I've made some doozies. Let me tell you, we're all human, right? We all make mistakes, so be aware. Checking your equipment before it's needed. This is a no-brainer. We beat this into everyone's heads from the time that they're in EMT school. Check your truck off every single day. Check it and know it what's there, know when it's not there. I do this every single day when I go into my room at work now, and sometimes something goes missing. Like, I'm not going to miss the balloon pump in the corner or the impella. I can see that that's not there, right? If I go and needed a temporary pacer to go put one in a hurry the other day, I'm like, where'd it go? It was here 2 hours ago, right where it's supposed to be. Sometimes people come to do things. If you work for a hospital, you have these cool little guys called biomed. They come by and work on stuff. Ours don't do a terribly good job of telling us they're taking something. They took the TP out of one of our rooms and didn't bother telling us they were doing that. Needless to say, I have to go running to another room to get a different one. But so, my fault. Before the case, I probably should have made sure everything was there again. I just didn't think anybody was going to come take the thing. Non-professional attributes. Put your ego first. See no reason to improve. You get on the scene when convenient. You feel no need for continued education. We talked about yesterday, what are those the defendant's qualifications? They had a North Carolina paramedic card. And I'm not going to rehash that story, but aims for the minimum standards. That whole 70's 100, right? Said C's get degrees, whatever you may want to call it. Protect yourself, hide, keep yourself in the bubble. And hope that the equipment will work when needed. I don't want to hope, I want to know. Political influence, and I had a huge discussion on political influence and policy on Thursday nights, every Thursday night now, for the next 13 weeks. And EMS is no different from this. We're revving up to the election in the next,
18 months.
18 months, 20 months, somewhere in there. So we're going to really start to take off in about October. But critical care paramedics should know the entities that are opposing their presence, understanding the forces that prepares critical care paramedics to interface with those forces at work, help bridge the divide between them. And role of a critical care paramedic in a hospital is not to replace other healthcare team members. Our goal is to facilitate and enhance patient care. We're not there to take. I'm going to use my field. We're not there to take nurses' jobs by any means, and nobody's ever going to do that. That's not going to happen. So, nursing has had a long contentious history with critical care in some instances. Medics get their perspective and the kind of get her done mentality. The broad scope seems to be a good fit for certain areas of expertise, where nurses are typically a holistic perspective. We're looking at the long term and the whole patient. Critical care paramedic is an unlicensed provider concerned with skill provision and allegedly lacks the breadth of knowledge offered in nursing school. I see as seldom distinguishing between an EMT, a paramedic, and a critical care paramedic. It doesn't matter. You are the guy on the ambulance or the gal on the ambulance.
To the ambulance driver.
You're the ambulance driver. So just be aware. There's a perspective. And this is not completely whole and accurate, but even I know critical care nurses who, nurses who are MICNs that have this perspective too. They don't do it anymore, but just FYI. These are reinforced by nursing labor organizations, fearing the loss of nursing jobs. No one fears that loss right now. God, we need more of them. But walk softly, do your job the best of your capabilities, be professional, be polite, take care of your patient. I say that if you can't set an example to follow, at least try to serve as a warning for the rest of us, right? I always thought this was cute, but try to evoke the image that you want to be seen. And try to encourage everyone to do that. And I'm going to pick on Jenny's buddy here a minute. He may not have all the knowledge and skill, but he looks like he does. And he knows how to play the political game. Just as that guy that isn't necessarily the most has the largest breadth of skill. But not saying they're incompetent by any means, but they don't try to paint a negative picture of the profession. They try to do the best they can. They're professional, and even though they can't, where's my